Hello, everyone. Thank you for joining us for our session on VEDS management and genetics basics. My name is Ryan, and I am the director of the VEDS movement. And I am also a genetic counselor by trade, have practiced genetic counseling for almost 17 years before joining the foundation. So I'm going to be talking a little bit about genetics. And we are also joined today by Dr. Shane Morris. Dr. Morris joins us from Texas Children's Hospital and Baylor College of Medicine. She's Associate Professor and Medical Director of Cardiovascular Genetics, a member of the Marfan Foundation and the VEDS Movement Professional Advisory Boards, and Vice Chair of the GenTAC Alliance's Collaborative Clinical Science Working Group. So I'm going to speak just briefly about some genetics basics and an introduction to the VEDS movement and some of the resources that we provide. And then I will hand it over to Dr. Morris to talk about management. And I officially shared the wrong screen. So one moment, my apologies. Here we are. All right, so as I thought about what I was going to chat about with regards to genetics basics, I figure if you're coming in for VEDS 101, you're coming here to hear about genetics for a couple of reasons. Number one, maybe you have a recent diagnosis of VEDS, and you want to kind of lay the foundation, the groundwork with regards to what is the genetic cause for this condition, what causes VEDS, and then that sometimes that's delivered with a little bit too much science, a little bit too much to take in, and perhaps you know very specific information about your mutation type, but really that initial foundation was never laid down properly. And it's important to have a nice firm foundation when it comes to understanding your condition. And so this is a very basic genetics talk. I could spend way more time going into a lot more detail. But that said, I'm a resource to the community. If you ever have any questions, if you want to reach out and learn a little bit more about your specific mutation type or something like that, please do not hesitate to reach out to me. To understand VEDS and to start at the very beginning, our body is full of connective tissue. So our connective tissue is like the glue that helps to hold our body together. It provides support, it provides structure and strength and protection. And so if one has a connective tissue condition, there is something different about the connective tissue where it's not able to provide as much support and strength as it should. And so when we think about connective tissue conditions like Marfan, Loeys, Dietz, or VEDS, you'll see that a lot of those conditions have some overlap. They have some symptoms that are similar amongst them all. And that is because the underlying connective tissue is being weakened for some reason. And that some reason is typically a genetic reason. So as we think about genetic causes for Ehlers-Danlos syndrome, there are actually a number of them. There is a sort of a larger umbrella of Ehlers-Danlos syndromes. The number can vary, but I've seen as many as 14 different subtypes of Ehlers-Danlos syndrome or EDS. And amongst those conditions, there can be a lot of similarities between them. What makes VEDS a little bit different is, with regards to, the fact that there are some life situations that can go along with VEDS. And we'll talk a little bit more about some of the signs or symptoms of VEDS here in just a moment. But it's definitely a different condition, a different entity from the other types of Ehlers-Danlos syndrome in that regard. And it's important to recognize those differences. So the gene that causes vascular Ehlers-Danlos syndrome is called the collagen 3A1 gene. It's not that gene actually causes VEDS. We all have that gene. And so, if you hear someone talking about genetic testing, they may say, well, I was tested for the collagen 3A1 gene. We all it's a gene that tells our body how to properly build some of our connective tissues. And so when we do a genetic test, we're not looking to see if somebody has a gene. We all have that gene. They're looking to see if there's some reason why that gene is not doing its job properly, why it is not providing the correct instructions to our body with regards to, telling our body how to build those connective tissues properly. This condition is called an autosomal dominant condition. What that means is if a parent has VEDS, each child has a 50-50 chance of inheriting that condition from either mom or dad. And so that is the autosomal piece. It means that this condition doesn't care if it's being inherited from mom or from dad. It doesn't matter if it's son or daughter. It is strictly a 50-50 chance that if a parent has VEDS, that each child has a 50-50 chance of having inherited that condition from their parent. If a child does not inherit that condition, it's not something that can skip a generation. So if one has VEDS, then their child does not inherit that from them, then that child's children or those grandchildren are not at risk for the VEDS that is in the family. About half the time, an individual with VEDS has inherited that condition from one of their two parents. And about half the time, it's a new genetic difference that occurred just in that child alone. And so in theory, that child's siblings really shouldn't be at risk for VEDS. How does that happen? Well, I always think about passing genetic information like copying a really large book. So if you had a huge book and you're handwriting a copy of that book, there's a chance that you might have some typos along the way, especially the larger the book. And I'll tell you what, our genetic code is a really large book. And so some mistakes might slip through the cracks. And our body does have a spell checker in place. There are some ways that it can go in and identify some errors that were made. It can go in and fix those. But if it's a really large book, even the spell checker, as you're aware, probably can't catch everything. And so sometimes a mistake may slip through the cracks and it may impact a gene so that the gene cannot do its job properly. And so, that is how we can see that someone might be sometimes the first person in their family to have a specific genetic condition. I briefly mentioned that we can talk all day about mutation types. I don't have that kind of time available tonight, but I'm happy to answer questions through our Help and Resource Center after the fact if you want to know some specific information about your genetics. But really what it boils down to is folks with VEDS either have the condition because that collagen protein is not shaped properly or because they're not making enough of it. Okay, so there's two types of genetic differences. If we really wanted to get very basic with it, there are two types of genetic differences that cause VEDS. One, it's either that the protein is not shaped correctly, leading to weakened connective tissues, or that the body is just not making enough of it. And again, we chatted a little bit about genetic testing, and I'd already mentioned this, but so when we do a genetic test, we're looking at that genetic code, we're reading the letters, we're looking to see if there's any reason to believe that that collagen 3A1 gene is not providing the right instructions for the body to build those connective tissues. I'm not going to spend a ton of time here because I know that Dr. Morris will go into these things a little bit further as well, but really the main and most important features of VEDS that medical professionals, emergency room doctors need to be aware of is the increased risks for arteries dissecting or rupturing, tearing of arteries, or tearing of hollow organs, specifically the GI tract or the uterus. So organ ruptures are part of this condition. Something called carotid cavernous sinus fistula. The way that I picture this condition is that you've got highways in your head and neck where blood is traveling very fast, and then all of a sudden a highway inappropriately dumps into sort of some of the smaller roads that are going through the neighborhoods, and you can imagine that that can cause sort of an increase in traffic or an increase in blood pressure behind the eyes. Oftentimes, one of the very first symptoms that someone with VEDS may present with or come to the hospital with is something called spontaneous pneumothorax. So sort of a spontaneous tear in the lung that causes some air to get trapped between the lung and the chest wall, and it can be very painful. And a lot of times it's actually one of the very first features or symptoms that someone may see. We can see increased healing and bruising, and sometimes this leads to diagnoses in very young children. It may be their first evidence of this condition is that their skin bruises very easily, and so they may go see a hematologist, get worked up, and they may find no problems with the way that they form blood clots or anything like that. And so, a really savvy doctor, or maybe if they see a geneticist, might at that point maybe recognize some of the facial characteristics that go along with this condition. And then there are some oral changes and muscle and tendon ruptures and some various things as well. You see a term on the right side of my slide there that says variable expression. What this means is that not everybody shows VEDS in the same way. Not everybody has their first medical event at the same age. Some individuals are more mildly affected with this condition than others. And the reason for that is probably sort of our other genetics and then environmental factors too. And the reason that we know it's a little bit more complicated than just that specific gene mutation that's running through the family is that in some families, you may have one person who carries that mutation who is living into their 60s or 70s and really hasn't had any major complications related to their VEDS. And they may have another family member who maybe passed away in early adulthood or even childhood, even though they carry that same genetic mutation, they're presenting a little bit differently. Their story with this condition, it can vary. And so we know that there are other genetics and environmental factors that make things a little bit more complicated so that we can't just look at someone's specific genetic mutation and make any really good, reasonable predictions about what this is going to mean for them. Very briefly, just a little introduction to the VEDS movement and what we provide. Number one, education and awareness. So we need to know that our physicians, emergency department staff, first responders like firefighters, EMTs, paramedics, they need to know about VEDS. And if you have VEDS, you need to get to know these people and let them know that you live in their area so that they are prepared to help you the best that they can if there were to be a medical emergency. So we develop lots of educational resources, put on lots of conferences and symposiums to help to educate not only providers, but help to educate the community too, because the best way that we can advocate for ourselves is to know very well our condition. We do a lot of social media campaigns. In October, we have VEDS Action Month, again, to increase education and awareness of this condition. We look to support the community. So through a grant from Dr. Daskell Family Foundation, we can provide free medical IDs to those that have genetically confirmed VEDS. Lots of community events, including Walk for Victory. You see there Camp Victory. So it's summer camp where a child can be surrounded by other children that are living with connective tissue conditions and just kind of get it, but also a staff that can help to ensure that the child stays safe while at summer camp. Lots of virtual support group offerings as well. We have a hospitality program so that if someone has a surgery upcoming or is hospitalized, that we can put together a care package. Thanks to the Lerman family, put together a care package to help to make their hospital stay a little bit better. And then, of course, frequent conversations with researchers to see how we can move research forward in order to help to identify more effective treatments for VEDS. Just a couple of quick images of some of the resources we provide. So again, free medical IDs. We've got little cards that we developed that can be brought to your physician where they can actually take advantage of free educational opportunity to learn about VEDS. We've got a sign that can go on the hospital door or the hospital room whiteboard or marker board. That is basically a big stop sign to say, hey, you need to stop and you need to read this critical information about the person that's staying in this room so that you can provide the best care to them. And then we also have lots of other resources that have been developed. So an emergency preparedness kit, which can be a little bit daunting, but I encourage people to work through that and fill that out. There's an emergency alert card that has been developed, as well as a first responders quick guide. I encourage people to just keep that information by their front door. In case of a medical emergency, the best thing that we can do is to be prepared. So on that note, again, I kept this very brief and very short and to the point, but again, if you have any more detailed questions, there will be a Q&A session at the end. And as well, please feel free to reach out to our Help and Resource Center at marfan.org/ask, or my email address is readily accessible on the website as well. So on that, I will bring forward Dr. Morris.
Hello, nice to see everybody here. I'm really excited to be participating today. And let me just go ahead and pull up my slides. Great, so we're going to talk about VEDS clinical presentation and management today. And please feel free to put any questions in Q&A and Ryan and I can answer them at the end. Can everyone hear me okay, hopefully? I'll just look at the chat. All right, great, I think we're good. So, and I see all the thumbs up. Yes, thank you so much. I don't have any disclosures. So first, we're going to talk about Ryan talked about the genetics and the major manifestations. We're going to go into a little bit of the details about the complications and emergencies, and then our management, which entirely revolves around trying to prevent these or minimize the sort of severity, the morbidity, which is how ill you get, or potential major life-threatening risks of this. So, of course, the one we most think about is aortic arterial aneurysm, dissection, and rupture. And I'm going to go through a little bit of the difference of these. So first, we're going to talk about aneurysm. So an aneurysm is just a stretched out blood vessel. I mean, it can be stretched out anything, but we're talking about arterial aneurysms. The arterial system is the system that pumps blood through the body. There's arteries take blood out of the heart, from the heart to the rest of the body. Veins come back. So it's the arteries, these muscular vessels. They go throughout our entire body. The biggest artery is the aorta, which comes right out of the heart, but it can goes all the way down to our arms, our brain, our legs. And aneurysms can look like this. This is iliac aneurysms, or they can be in the aorta. And so we call these thoracic aneurysms, thoracic aortic aneurysms. This is one in the area called the root. This is right as it's coming out of the heart, or this is ascending aorta right here. That is what an aneurysm is. Now, in VEDS, most patients don't actually have aneurysms before they have a dissection or rupture, which we're going to talk about in a second. Now, if you've heard of the conditions Marfan syndrome or Loeys-Dietz syndrome, which have a lot of things in common, they tend to get aneurysms. They can get aneurysms anywhere, all over here. And we certainly can see aneurysms in VEDS, for sure, as people age. But in Marfan and Loeys-Dietz, in order to have an artery tear, which is a dissection or a rupture, you almost always have to have an aneurysm first. But in VEDS, your vessel and imaging can look totally normal. There can be no aneurysm, and then you can have a dissection or tear. But an aneurysm itself has no symptoms. We just see it on imaging. So what's a dissection, aortic arterial dissection? So what this is if you look at any artery, it's got these three layers, an intima, a media, and adventitia. And what a dissection is a partial tear. It's a tear through one or two of these layers, and the blood goes in between the walls and then starts going up or down. So in the aorta, which looks kind of like a candy cane, if you look from a side view like that, what happens is the blood comes in here and stretches out the difference between this wall and makes sort of a second lumen. And so this, which it's not a rupture where it goes through and through, it's a dissection. So the blood is dissecting or kind of tearing through the planes of the artery, and this can cause severe pain. This is a dissection sort of in the back of the aorta and can cause two problems. It can make this wall very thin, predisposing it to a rupture, or it can cause so much pressure in this extra lumen that it actually compresses the aorta or other vessels and can limit blood flow. And there are these two blood passages. Oh, sorry, one of my words was hidden there. So an arterial dissection, I just showed you an aortic dissection. An arterial dissection can happen up in smaller vessels too. So this is one where the blood has gotten between those two layers, and you can see this isn't a carotid artery. It's compressing. So this is how the blood would go up to the brain. This is a neck vessel, carotid artery. You can see if there's a dissection, the vessel is not bulging out, but it's bulging in. And so the blood getting up to the brain can't get there. And that's why neck artery dissections can cause strokes, because they keep the blood from going up, or they can cause something before that called a TIA, transient ischemic attack, which is where it feels like a stroke, but then it gets better as the blood reperfuses. And so again, this is just looking here. This is the blood that gets in the walls. It's slow flow, so it clots. So the blood can't get through, unlike normal flow. And this can happen in any artery of the body. So a rupture is where the blood tears through and through all three layers, and it exits the arterial system. And this can also happen in VEDS. It can happen in the aorta, it can happen in the neck. And, a common one is a subclavian artery, which is an artery that comes right off the aorta. And this is, dissections can be surgically treated. Aneurysms can be surgically treated. A rupture, if you're not in a hospital facility, is extremely hard to do anything about, because this is pumping at blood pressure and it's very high. So we really, really try to avoid these at all costs, a rupture. And I've taken care of a couple of people with ruptures, thankfully, that were in the hospital and survived. But if you're not in a hospital setting, it's pretty hard. So Ryan mentioned that carotid cavernous fistula. So this, again, you have this artery, the carotid artery, the neck artery, as I just showed you, that comes up through our head. It comes all the way up to the brain, and it happens to pass through the sinus that happens to be behind the eye. And what can happen, like he said, this is a really high velocity artery. It's going through this low velocity cavern. And sometimes there's a little bit of erosion, a little bit of a hole, and then this high pressure goes into this low pressure and can cause a lot of pressure on the eye. And this is very rare. And if you see it, you should think of VEDS. And what it looks like, you get this red bloodshot eye, pain behind the eyes, blurry vision, and weak movements. Normally, I just had a patient with an asymptomatic one of these, but most of the time this is what you get, and it is an emergency. And what they do is they embolize, they put like a little coil in here to stop the connection. A fistula is just a connection between the artery and this sinus or hole, which is like an open part of the skull. And so the blood doesn't go in there and put pressure on the eye. Pneumothorax, as Ryan mentioned, is a lung collapse. These are just some pictures here. This is a picture of an x-ray. So the heart is here, the right lung is here. And if you see, there's kind of light gray blood vessels all the way out to the periphery. But if you look here, there's light gray blood vessels out to here, this line. All of this is air. So air shouldn't, even though air should be in the bronchi of the lungs, the airway, this shouldn't be outside. This is air that's escaped outside the lung, and it's compressing the lung. And can be, if it's small, it can be not an emergency. You just need a little oxygen. If it's big, it can be a huge emergency. This is a diagram of the same thing where it's collapsed because of air outside. This is common in VEDS and can be treated pretty easily with a chest tube. We have great treatments for this if you get care, but sometimes when people are having chest pain, they think they're having a dissection, but it's a lung collapse, which is a much more benign thing for most people. So other complications that aren't as severe, but can certainly be problematic to your life are hernias. Groin hernias are really common. This is, in the pelvis where where your fascial area is, the intestines sort of pop out through thin skin. You can get recurrent joint subluxation, dislocations, which can cause a problem. That tissue just is not as strong and can be irritated, pop out of the socket. Another major complication is intestinal rupture. And I know I'm going through these quickly because we're doing all of VEDS in just a few minutes, but this is where the bowel wall sort of gets little fistulas or tears in it. And that can be a major problem both for getting air and getting, matter from the intestines outside, which can cause major infections. And so this usually presents with abdominal pain. It can be progressive, be tender, you don't have an appetite. It's often diagnosed as constipation. It can be really hard to tell because especially in young people, intestinal ruptures are really, really rare. But it can be treated with surgery to repair or protect the intestines as long as it's picked up before like a massive infection. And we just had an incredible case where a teenage girl presented with an abdominal rupture, an intestinal rupture, and the surgeon who sees a lot of VEDS because he works at our hospital, his trainee called me and said, Dr. Morris, we just had this intestinal tear, and this girl's really slight and thin and has thin skin. Do you think it could be VEDS? And, the surgeon diagnosed her VEDS just based on the bowel rupture. So pretty impressive. And she's doing great. Other more minor, well, they're not minor to the patients, to you guys, but these hematomas, which is the big blood collection, and vein ruptures. So under the skin can be super painful. They can last, usually you get a bruise that lasts a few days, but these can last weeks to months sometimes. They can get hard underneath the skin and can cause a lot of discomfort. So what about management? How do we manage to try to minimize the effects of VEDS and really have, the longest, healthiest life possible? I mean, that's all of our goals. And I want to learn from you guys too. And I'm always trying to get advice from people who experience this. I tell you what we will do. We do serial imaging, lifestyle modifications, surgery or endovascular intervention when needed, only when needed. Advocacy, a big part is advocating for yourself during emergencies, because a lot of VEDS is knowing what's going on and getting a diagnosis earlier. And I'm going to talk for a long time about medical therapy because there's a lot to discuss about that. I'm going to briefly go through the other things. So serial imaging, this is taking pictures of all the blood vessels. It's pretty debated because, as I mentioned before, people with VEDS can have ruptures without any aneurysms. So some people historically have said, well, why take pictures of the vessels? Because I can't predict it anyway. I think most people now do recommend extensive imaging, knowing though you may not pick up a warning, but certainly we find aneurysms sometimes and then can follow them and know that's an area is at risk. So usually this is done with either an MRI or MRA, that's a magnetic picture of all the vessels, versus a CAT scan. But sometimes if you've had stable pictures, you might do ultrasound, especially in adults, ultrasound of all the major vessels. Sometimes in children, we also use echocardiography, which is just ultrasound of the heart. Echo is good at picking up aortic aneurysms, or dissections, but not the rest of the body. And all the MRI, CT, and some forms of ultrasound can pick up the ones that are more peripheral. And I do think most practices now recommend standard arterial imaging, in the beginning every 6 to 12 months, but then depending on how severe and how many events you've had, might space that out. And certainly in children, it's much more spaced out. So lifestyle is really avoiding activities that are prone to bodily injury. So we usually recommend against competitive contact sports. We do want people to be active and have fun and play and not become couch potatoes. But, activities where you're going to be hit really hard, we want to avoid. Heavy weightlifting, we know that when you're bearing down, your intrathoracic pressure is really high and can lead to arterial injury. We recommend against trampolines. Mostly, it's not always the person jumping, but other people jumping with them, much more prone to injury. Trampolines are already one of the #1 causes of major injury to children, not in VEDS. So you add VEDS to that, that can be a major problem. And of course, extreme sports like bungee jumping, skydiving, all those things where you can have a major injury. Surgery and endovascular intervention. So this is when we find an aneurysm. Certainly we intervene if there's a major dissection or rupture, but if there's a small dissection that looks like it's healing, like a vertebral artery, people often get small vertebral artery dissections that might heal. So we often use observation. Although if we need to do surgery, we can. And I'm sure you'll hear Dr. Shalhoub to talk at some point, who's a vascular surgeon that specializes in VEDS, but we sort of do those same surgeries you would do on someone else that had these. We just do it a lot more carefully. And historically, we used to say, well, it's not worth operating because things are so dangerous. But we've learned a lot about VEDS. We can be careful. And so we certainly do surgery when needed. I just had 2 of my patients undergo knee and hip surgery, and they're doing really well. People just take a lot of caution. So this is a nice paper led by Dr. Shalhoub talking about different intervention. It's a multiple aortic and arterial aneurysms, dissections, and ruptures in people with VEDS, but it talks about some of the elective interventions that were done. So, and the last thing before I get to meds is talking about advocacy during complications. The biggest part of VEDS, I think, in having a longer, healthy life is knowing you have it, presenting to medical care right away, and letting them know you have VEDS and what they need to do. Especially people tend to get events young. The average age of a normal aortic dissection is like 60, 70, and people could be 20 or 14. And certainly vertebral artery dissections are usually start in middle age, but they can happen in your teen years. And so letting people know they have VEDS, advocating, using whatever resources you have so that they know to get CAT scan right away, whether it's for the abdomen or the vessels, and reaching out for help. A lot of us are here. My patients all have my home number, my cell number. Having a resource. I know there's a hotline with the VEDS community, so that you can get help if someone's not listening, because that is a huge part. If you get imaging earlier, you can get intervention early. So now I'm going to talk about meds. Lots of complexities in VEDS meds and no great meds currently, but just to help everyone get really educated. So the first real study on VEDS was called the randomized controlled clinical trial. This was published in 2010 in Europe. And it used a medicine called celiprolol, which is a beta blocker, which is a medicine that basically dampens our response to adrenaline. And they randomized patients to either get celiprolol or to get a placebo, a sugar pill. And basically, they enrolled 53 patients in France and Belgium. It was 8 different centers who had vascular EDS, and they got randomly assigned, you either get placebo or you get celiprolol. There were some children, they aged from 15 to 65, and they were followed for 5 years. And they looked to see if either group had a difference in who had a dissection or rupture of an artery. And in the group getting a drug, 5 of the 25, 20% had a major event. And in the placebo, 50% had an event. So this was looked at and said, oh my gosh, this is such a big difference. Celiprolol is absolutely working. We're going to stop the study early. This is amazing. And it was really hailed as a huge success that the celiprolol seemed to work so well. There's been a few limitations of this study, however. So they concluded celiprolol should be the treatment of choice for physicians to prevent major complications, but a lot of controversy came out once it was published. So not every patient had been genetically tested, had gotten the call 301 testing, which is standard of care now. So when they tested, they were only able to test 51, and only 33 really had VEDS. So that made the groups way smaller, and the intervention group only had 13 patients with VEDS. So also it was open label. So people knew whether they were getting the placebo or not. And there's, this is a big thing in trials, but there's a little bit of bias that if you know you're getting a drug, you might be less likely to report symptoms. Now, this was looked at imaging. So, we hope that that wasn't biased, but it's always a possibility. And because of these two limitations, there's been varying investment in how much people believe this trial, and it's led to practice variation around the world. And I drew this little map, but basically, this was tested in France and Belgium. And so most of Europe, because this is where that study was done, does prescribe celiprolol in VEDS, and including parts of the UK. Now, I think there's been less take up in the US. Now, certainly I'm in Houston, and most of my colleagues here, which is where we see a lot of VEDS patients, we do give beta blockers. Now, I will say celiprolol is not available in the United States, so we give a similar one. I think we're not 100% sold on the meds, but they're very, very safe. And we figure if anything can help, great. And they have very few side effects. I think in the Seattle area, in general, the practice, it certainly varies. If you've had an event, you'll be on meds. But if you haven't, I think there's more reticence to start medicines for some people, some providers. And then angiotensin receptor blockers are ARBs. Losartan is the most common. We use a lot in Marfan syndrome, and a lot of that work has been done in the East Coast and Baltimore area. And that has worked really well in some Marfan and Low-Disease mouse models. And I think there is a thought that some of the benefits seen in Europe was from the blood pressure effects, and the ARBs have really good blood pressure effects. And so why not use those? So a lot of the East Coast uses ARBs, losartan, as well as part of UK. So you might hear in boards that people are on different meds, and that's because we don't really know what's best on current use. So these are kind of the three things most commonly done. I do think most people agree that if you've had an event, you should probably be on something. But if you've never had an event, I think the jury is still out. Now, that French group did do a long-term study on VEDS, and they followed people, 107 subjects that had at least 2 clinic visits, but most of them were on celiprolol. And so there was no control group in the follow-up. They just said most are on celiprolol, and they showed that compared to their prior era, people were living longer and having less events. And it's a little bit of a question, like, are they living longer and having less events because we're better at caring for it, or is it because they're on celiprolol? So we still don't really know if celiprolol works, but it's kind of the only human data out there. There is currently a trial by Acer Pharmaceuticals going on for, I think, adults or maybe very older teens and adults looking at using celiprolol versus placebo in the United States right now. So this was their survival curve published in the study, which if you guys, I should have put it, I don't think I put the historical study, I'm so sorry. There was a historical survival curve that was much lower than this. And they sort of said, compared to history, we're doing much better. And this is because celiprolol, but we don't know for sure. I mean, I do give beta blockers, but I don't know how well they work. So then there's been, you guys might have heard, there's been some really exciting new work in mouse models from Dr. Dietz's lab with Dr. Bowen, who's one of his researchers. And basically looking at this molecular pathway that they think is contributing, and I know this is a bunch of fancy words, but basically there's a mouse, 2 mice that have VEDS, and they've created mouse lines, and they've realized that this one pathway seems to be really altered in mice with VEDS. And if they target this pathway, then we can reduce arterial events, these dissections and ruptures. And the mice, what happens is the mice is alive, they're fine, and all of a sudden they have blood in their chest, and they think this is an aortic or arterial rupture happening. And so this was a landmark paper written by this group in 2020. And what they showed is they gave the mice basically a med that blocks this pathway, and compared it to the mice that weren't on that med and looked at survival. So if you guys haven't seen this, this is called a survival curve. And what it is this is birth, this is time of starting the medication, this is number of days on the medication, and this is number of patients or mice in this situation alive. So everyone starts alive. And then you say, like, by day 20, the group not on meds, 80% of the mice were alive versus, 95-ish. You kind of drop a line and say, what line are we at? But if you got 40 days on the med, 50% of the mice not on meds were alive versus 95%. So this ruboxysturin looked really good for helping VEDS. And so that led to a randomized controlled trial by A2 Biopharma for a similar medicine called enzasturin to prevent. And that was going on, that was about to start a few years ago. This it modifies this PKC pathway. But unfortunately, that company ran out of money, and that trial has been paused. Now, as part of that paper, they looked at lots of the normal meds we give in VEDS, like the normal blood pressure meds, as kind of a comparison to look as well. So they did lots of experiments. These are all survival curves. I'm going to walk you through a little bit to kind of help you understand what's going on here. So first they said, okay, well, let's look at some of the meds I talked to you about. I talked to you about losartan, which is one of those ARB meds, and anything ending olol is a beta blocker like celiprolol. So they looked to see, was there a difference in any of the drugs in the VEDS mouse, just using the normal drugs. And the one way we use to compare, I mean, you can eyeball and see if the lines cross or look different. You can always look at this P, and if the P is bigger than 0.05, it means there wasn't a difference. So in the mouse model, whether they gave losartan or propranolol or atenolol, there was no difference. None of those seemed to help in the mouse model. Now, mice aren't humans. This is mouse data, but just to go through it. Then they actually got celiprolol, the beta blocker used in Europe, and there was no difference. And in fact, the celiprolol group seemed to die a little sooner, seemed a little worse, which was inconsistent with the human data, but was what they found in the mice. Then they tried celiprolol. They tried celiprolol they had two versions of the mouse. They have kind of a more severe mouse with VEDS and a more mild one. And this one, the mild form didn't have any events, and the one on celiprolol had more events. So these two were a little concerning that celiprolol in this mouse seemed to be making it worse. Now, then they tried another med. It's called the calcium channel blocker. It's a different blood pressure med called amlodipine. Didn't do much. They tried a different blood pressure med called hydralazine, which is a totally different kind of blood pressure med. And it really seemed to help. So this is the group not on meds. This is the group on meds. This is less than 0.05. So we say, oh, the hydralazine really seemed to work. That's really impressive. However, it worked, but then they started having events around day 40 in. What they realized is that around day 40 is when these mice are starting to go through puberty. And the thought was, well, maybe there's some pubertal, like androgen effects causing this. And so what they did is they tried blocking androgens, and I didn't show that slide, but they skipped to something called spironolactone, which is a very mild androgen blocker. And what it did is it kind of rescued, and I'm sorry, this is the one that keeps going down. It rescued this. So this group did not have these ones dropping down once we hit puberty. And see that the group, if you use hydralazine plus spironolactone, no events, versus the control group that had lots of events. So this was kind of a secondary finding of like, wow, hydralazine plus spironolactone could work. It worked in the mice. Now, hydralazine is available for humans, but it's a very hard drug to give. It has a lot of side effects. It's every 6 hours, short acting, and it was thought to be pretty impractical to actually prescribe this to people. Oh, sorry. Okay, I'll keep moving through. So I'm going to show some unpublished data, but it's on the internet. It was presented with us, but it hasn't been published like in a journal form from this same lab. That's kind of exciting. So at the 2021 VEDS International Meeting, the question came up of what if we didn't give hydralazine, but just gave spironolactone? Could that help the mice after puberty? And in fact, just giving spironolactone helped reduce events by itself almost as much as the hydralazine plus spironolactone. And then a year later, they came back and used a different med called eplerenone. Now, eplerenone is a similar med to spironolactone. So I had said spironolactone is a androgen blocker, like a testosterone blocker, very mild. Lots of people take it. It also blocks like salt signals, like salt retention. And eplerenone just does the salt without suppressing the androgen or the testosterone effect. So some people were worried, like, what if we give this mild testosterone blocker to our male patients, could there be side effects? So they tried giving eplerenone instead, and it also helped, not as much as spironolactone, but also helped. And so this has generated a lot of discussion whether we should try these medicines in humans. They're already available. They're used for heart failure. They're used for some other reasons, polycystic ovarian syndrome in women, acne. And so whether they should be used in VEDS. And that's kind of, you might hear a lot of information about that, but there's been no human studies of these in VEDS so far. So there was a really nice VEDS research update written mainly by Dr. Dietz. And then we did a webinar. Dr. Byers and I helped moderate it. It's a nicely written statement kind of talking about all of this research that you can find online through the Marfan Foundation. So one other thing to follow up, and I know we're getting short on time, but there was another paper from the Paris group looking at their mouse model of VEDS, and they did not see that the same pathway was activated. And they found totally different genes that were affected, or proteins that were affected, and they seem to be in the inflammatory cycle or in the inflammation signaling rather than this PKC or pathway. And they did the same thing. They did a bunch of studies with meds. This is looking at, they showed the same thing though, that propranolol and celiprolol, no effect in their mice. They showed that amlodipine actually looked worse. This is that calcium channel blocker that had no effect in the other one. Hydralazine, they showed did help, kind of like, so this looked very similar to the other study that hydralazine seems to be protective in the mice. But they showed that losartan actually was very protective, unlike the other study that didn't. So it's conflicting results, different pathways. And the other study said losartan didn't help. This study said it did. And that's kind of where we are. We don't really know what to do. I will say I work at Texas Children's, and we've really struggled with what to do because most of this is not published. It's not in humans. There's not a trial. And so what we do is if someone is interested in trying one of these meds, we will consider starting it if we think they meet criteria in a study setting. We have a long-term study going on vascular EDS. We test electrolytes because they can be affected. We have no idea if it's going to work because a lot of mouse studies don't work in humans. We do not stop the baseline therapy, which is a beta blocker and ARB for many patients, but other sites might be prescribing it differently. We're all learning right now. A lot of people aren't prescribing them. And so this is totally new territory for us all. So in general, our strategy at TCH for management is we do baseline head to pelvis imaging. We make sure families are educated. We do activity limitations for older children, not younger children. We do use beta blockers here, but not everyone does that. We do serial imaging, we try to minimize procedures, and we really work on family connections and advocacy. So basically, in summary, as I mentioned before, imaging, lifestyle modifications, thoughtful intervention, self-advocacy are super important. We need better research and better medical therapies for VEDS. The only human data supports celiprolol use, but that trial was very limited. The mouse data are conflicting between sites about celiprolol and other beta blockers. They're conflicting about ARBs. They do agree that hydralazine is effective, but that is a very hard medicine to take, and we don't know if it would work in humans. They do suggest that spironolactone and eplerenone could reduce events in mice, and there's this outstanding question whether it would help in humans. And I think we need funding for a creative human trial. I think that's it, and I'm happy to take any questions with Ryan. Oh, I can't hear you.
Yep. So first, I understand that I was laggy, and I hope that that there wasn't any critical information that was missed. But I am very accessible, so my email address is on the website, or you can submit questions via the Help and Resource Center at marfan.org/ask. So if there is something you missed with regards to the genetics basics that I had provided, please do reach out. So we do have a handful of questions that have come in through the Q&A. The first is varicocele a common finding in VEDS, or just at regular risk for that?
Yeah, I don't know if we have population prevalences. I follow about 50 kids with VEDS, and I have at least 2 that have it, which I think is probably above the population prevalence. I suspect that it does have a slightly increased risk in VEDS.
Okay. What imaging do you recommend for someone that is postpartum?
And the mother has VEDS. I mean, that's highly variable. It hasn't really been studied. I think at our center, within 6 months of the pregnancy, they would for sure, I mean, probably within a month of the pregnancy, but for sure within 6 months, they would get head to pelvis, either CT or MRA, because there's just so many hormonal changes that are happening. And vascular, you go from double the cardiac output to half to like normal cardiac output. And so your vessels are all stretching and changing.
There are a couple of related questions, so I will do my best to sort of combine them. There is one individual that is asking about imaging of their children's aorta, that sometimes people are measuring on the smaller side with regards to their Z-score. And so just kind of wondering about what is the range? How often is dilatation there? How often is there a lack of dilatation, or even a smaller measurement? And sort of what does that mean?
Yeah, so I think the lack of aortic, so most kids in VEDS, at least we just looked at all of our patients, 15% of ours were dilated, had a dilated aorta. The ones that did were pretty mild, except one person who had something called bicuspid aortic valve, which is like a common congenital anomaly that makes your aorta bigger. That patient had moderate, but none of those patients had had an event, even though about 15% of our patients have had an event. So it doesn't seem, the aortic size does not seem to correlate with the risk of events. However, if you do have a dilated aorta, we're more likely to follow you closely and more likely to give you meds. I know of one patient who had, a bicuspid valve, which makes your aorta bigger, and VEDS, and they did have a tear at a pretty small size of the aorta. So it's more that if it's small, you're still at risk because you don't have to have an aneurysm in VEDS. But if it's big, we definitely worry more, and we'll have, at least in our practice, we would most likely have you on medications. But there's not a strong correlation because you don't need dilation to dissect.
And there is a related question that asked, why some individuals or some families with VEDS do have aortic dilatation, and others do not. And just very briefly, I had brought up the idea of variable expression. So it is all of these other genetic and environmental factors that we just do not fully understand yet that probably will help to paint a better picture and allow us to be able to make better predictions once we start to sort some of those things out. So if you wanted to add anything to that thought.
Yeah, no, I think they're probably getting aortic dilation from somewhere else in the family, but I think a lot of times mild aortic dilation is tolerated, but it may not be in VEDS because you have a more sensitive aorta as you age. But
at what age would you consider starting the restriction of certain activities for children that have VEDS?
So that's really, we have no data. So that's just like expert opinion. And they're just, so I think a lot of people have heard this, but a statement will be coming out from the American Heart Association on management of children, including exercise, medications, interventions. And so we'll address that. But kind of as a consensus, I can tell you what we do. We mostly won't restrict kids in elementary school, except like don't go on the trampoline, don't be playing crazy contact stuff. But usually once you get into late middle school or high school, competitive contact sports. But we also tell people really young, because you don't want someone to fall in love with basketball and then at 12 you're like, never mind, you can't play competitively. We try to tell parents from a really young age, so even if they want to play pickup basketball with their friend or flag football, they can guide them for their more competitive pursuits in a different arena, either lower intensity activities, sports, or into activities like art or drama or whatever, something that's not as risky.
And I know this can vary quite a bit from one institution to the next, but there is a parent asking about the age at which their child should consider start getting MRIs or various images with regards to their VEDS diagnosis.
Yeah, so again, we don't know data. I would say some people don't start until teenage years. I think because I have a particularly severe population for kids, which they're still doing great. I just tend to get kids once they've had something happen. So I always do head to pelvis imaging the first time I meet someone with a diagnosis, just to get a baseline, make sure we don't have aneurysms anywhere. We may not, if they're before 3, we may not get it till 3 because they have to be sedated often. But then we'll go a few years without, we'll get echoes to make sure everything is okay, but we won't do head to pelvis imaging for a few years unless you have had an event or have a severe variant. But some people will wait until teenage years to get it.
Okay. And there was a similar question with regards to the frequency with which their child should be imaged. And again, you just sort of addressed that a little bit, but it kind of depends upon the results of the previous image.
Yeah, and we have risk markers now in VEDS. We used to treat everyone the same, and we've developed a lot of high risk and low risk markers. So like if, as Ryan mentioned, if you have certain variants, so like a splice site variant or a certain glycine variants, you're higher risk. If you have a high tortuosity, that's twistiness of the neck vessels, you're at higher risk. If you've had a preterm delivery, we think that is due to an amniotic sac that was affected by VEDS. And so we wrote a paper that showed that babies born preterm are more likely to have events early. So we risk stratify everyone when we see them in clinic and say, of all the high risk, low risk features, what do you have? And the more higher risk, the more frequent you're going to get imaging, and the lower risk you are, the less frequently you're going to get imaging.
And just recently, actually, there was a Dutch study of a cohort of 142 Dutch individuals with VEDS that did look at some of those trends as well. So we just actually posted a summary of that article and the article itself to the VEDS Movement website today. So I'd encourage you to go check that out. We do have a hard stop at 5:50 with regards to getting the next set of webinars going. There are a handful of questions in the chat with regards to the celiprolol trial, and some people that had missed actually a webinar early in the day. So I will encourage you all to check out the re-airing of our VEDS research webinars. Those will air on Friday, I believe at 3 and 4 p.m. Eastern, if you missed them. Some of the data has been unpublished with regards to the arcade trial out of France, and so that one will not be available on YouTube. So I would encourage you to tune in when that re-airs on Friday, because otherwise that one will not be available. But Zevra Therapeutics talked about the US trial of celiprolol, and that one will be available.
Oh yeah, I called it Acer, but they changed their name. I forgot they got bought out.
Yes.
Thank you.
Yes. So thank you so much, Dr. Morris, for
Thank you, Ryan.
joining us tonight. This was wonderful. Thank you for your time, and thank you everyone for joining us. Again, if you have any questions that went unanswered, please do not hesitate to go to marfan.org/ask and submit them to our Help and Resource Center, where my email address again is very accessible on the VEDS Movement website as well. And happy to answer those questions directly, or if we need to tag Dr. Morris or some of our other professionals on our professional advisory board to answer your questions, we are happy to do so. Thank you again so much for your time, and everyone have a good night.
Thank you guys. Have a great night.